Thank you for joining the webinar on the APPG recommendations for the Tobacco Control Plan 2021. We have over 300 people signed up. At the moment, we've got 137 attendees and people are still joining. And that's people from the Smokefree Action Coalition, from local authorities, from the NHS, all who are interested in the tobacco control policy and the plan the government has under development. I'm going to start by housekeeping. Can I remind anyone who's not speaking to keep themselves muted, and ASH staff will mute anyone who's not speaking and isn't muted. The meeting is being recorded, and a recording of the presentations will be made available after the event and uploaded to the SFAC web pages, as will the presentations by Dr. Beard and Dr. Featherstone. Can you type questions for the Q&A into the meeting chat function at the right-hand side of your screens? The sooner you do, we're going to do all the questions together, so the sooner you put your questions in, the sooner we can consider them. So just to introduce, the All-Party Group on Smoking and Health was set up in 1974 and has a very honourable track record in producing recommendations for the government on tobacco control. So after the Minister's announcement last December that the government would be developing a new tobacco control plan to deliver Smoke-Free 2030, and with support and help from ASH, which provides the Secretariat for the APPG and the Spectrum Academic Research Consortium, we pulled together what we believe to be a comprehensive set of recommendations to achieve what we all want to see, a Smoke-Free 2030. I'll hand over to others to talk about the detailed recommendations, but I'd just like to point to the level of support they've received already and urge you as individuals and organisations to add your support too. They've been endorsed by leading health organisations like the Academy of Medical Royal Colleges, the Royal College of Physicians, the Health Foundation, the Faculty of Public Health, the Association of Directors of Public Health, the Royal Society of Public Health, British Heart Foundation, Cancer Research UK, Asthma UK, and the British Lung Foundation, and we're looking for many more. And the recommendations are not just supported by the experts, but if you read the report, you'll see there's very strong support from the public as well, both for the government's ambition and for policy measures needed to deliver it. Now, developing a comprehensive tobacco control plan takes time. The Minister initially committed to publication by July this year, but our priority is to secure a comprehensive and well-funded plan. So if it takes longer than July to do that, so be it. The plan needs to be in place in time before the end of next year, this year, so that it can be fully implemented in the next financial year. And we need to have the funding, so the funding mechanism must be in place, otherwise the plan cannot be ambitious. So as our first speaker, I'm pleased to welcome Sue Mountain, who's an ex-smoker and survivor of smoking-related cancer. She's going to give us her thoughts on the recommendations and why this matters to her.
Thanks, Deborah. I've unmuted. Hi, my name is Sue Mountain. I spoke at the APPG meeting last Wednesday on a report of tobacco control plan for delivering a smoke-free 2030. I asked the government to be bold and ambitious, have a comprehensive funding plan. To help with the funded plan, I certainly support the report of asking tobacco manufacturers to pay a levy or a licence fee to the government to help smokers quit, and also help prevent young people from taking up smoking. Why? This is my personal story of why I believe the tobacco companies should pay. I'm one of the 2/3 of young children that got trapped into smoking at the age of 11. I got hooked. Of course I did. That's what tobacco companies want. They legally sell a product that they know is addictive and they promote it as cool. My idol in Greece, Olivia Newton-John, not the shy Sandy who coughed when she smoked, but the Sandy that was approved by the gang by being lured into smoking to look cool, sexy. She got a man. Audrey Hepburn, the classy lady with a long cigarette. James Dean, I could go on. I wouldn't have started to smoke if product placement wasn't used by tobacco companies to promote it as cool and sexy, or if I'd known more about cancer-related smoking. I tried packing in so many times and regretted ever starting. But to smoke is an addiction, which is so difficult to stop without help. This addiction is no different to drugs like heroin. But with this addiction, we know the pushers. It's the tobacco companies. I continued to smoke until I got cancer of the larynx at the age of 47. I got told about my cancer in hospital, went out the hospital gate and had a cigarette. Really, I can hear you saying, yes, I was addicted and I needed a cigarette to help me. In my mind, I needed it. I got the cancerous cells lasered, and then it came back. Got them lasered again, and it came back. Came back more aggressive when I was 52, and then needed radiotherapy. I am lucky, I'm now free of cancer, but still get checked every 3 months. Can you imagine what it feels like to get the camera up my nose and down my throat? And the obvious thought, has it come back this time? The worry of cancer will always be with me, thanks to smoking, thanks to the tobacco companies. I totally agree with the report about smoking and depression. I couldn't find a way out of smoking, led to depression. I tried every time I tried to pack in, I failed. And there wasn't as much support years ago. I then became a single parent. How did I manage to find money for cigarettes? I did. I really did. And guess what? Felt guilty smoking, but I needed them to cope with life. I was addicted. Managed to buy the cigarettes, the more guilt I felt. Since quitting, I haven't felt half as depressed or anxious. And of course, I've got a lot more money. There are 6 million smokers in England. That's 1 in 7 adults. We must motivate more smokers to make a quit attempt. We've got to reduce the number of children and young adults who start smoking each year. It's not cheap. Public spending on tobacco is estimated at 40 billion a year. Tax revenues don't cover the costs of a smoking society. Survey carried out by Ash in March 21 found 77% of people supported making tobacco manufacturers pay. Of course, I agree. I want the pushers to pay. Get tobacco companies to help pay towards a smoke-free 2030. For those of you listening that are working really hard to help smokers quit, wow, I know how difficult it is to smoke. So I can't even imagine how hard your job must be, trying to get people to come off something so addictive. It must be really, really difficult when your budgets are constantly being cut by government, which is why I urge you and your organisations to get behind this report and get tobacco companies to pay and say smoke-free 2030. I honestly don't want my grandkids growing up in a smoking society. My youngest is 3. Hope she never comes across people that smoke when she's a teenager, and therefore she won't get lured into smoking. Let's be the first smoke-free country and back this report. Thank you very much.
I'm Ruth Sharrock, respiratory consultant in Gateshead, Queen Elizabeth Hospital, and clinical lead for the Treating Tobacco Dependency Task Force at the Northern ICS. Thank you for asking me to speak, Deborah. As a frontline clinician in our NHS, I'm enormously grateful for the breadth and volume, the depth of work that's gone into producing this report, and on behalf of myself, my colleagues up and down the country, wholly supportive of the recommendations. They can't come soon enough for an updated tobacco control plan. It's very hard to describe the experience of working through COVID on the front line on a respiratory unit. And like many, we lost one of our colleagues, Keith, a nurse on our respiratory wards. And I know NHS staff up and down the country lost colleagues too, devastating. but very much in the line of same vein as Chris Whitty's comments about smoking causing a more enduring problem, more smoking related deaths likely this year than COVID. This is my situation. I've lost 3 working age colleagues, people I work shoulder to shoulder with, Dawn, Caroline, Pearl, smoking related diseases, and I've looked after the relatives of many, many more. I've got patients with lung cancer on my books at the minute who have worked alongside. It's endemic, and it's not just the patients we're looking after and the communities we serve, it's the people we're working alongside as well. In addition to the colleagues affected by smoking related harms, it's the mainstay of what I'm doing here. We've got 2 respiratory wards at Gateshead. The mainstay of the clinical workload is exacerbations of COPD, emphysema, respiratory failure because of smoking, people requiring non-invasive ventilation, and obviously lung cancer and the complications of that. And that's the same as what we're seeing in outpatients. It's just day in, day out. My bread and butter is harms from smoking. So, you know, across the NHS primary care, secondary care, mental health services, maternity services, we just feel like we're firefighting the consequences of health harms from smoking. And I'm not sure we're winning, and we're not going to unless we embrace this sort of level and depth of recommendations. In, you know, close to home, Gateshead and Sunderland, a quarter of our expectant mums at booking in are smokers. And through COVID, we've had a 70% drop off in referrals to stop smoking services. So COVID's just, you know, driving an even deeper divide in the health inequalities that are perpetuated by people who are dependent on tobacco. And I wonder if I could just take a moment to tell you about a girl I've met a few weeks ago. I've told some of you about her already, but she's really, you know, caught us all. My office looks out over the labour ward, and I can smell if somebody's crept outside for a cigarette. So you often see me late at night scooting down the fire escape to go and offer them help and support and talk to them. And I met a girl a few weeks ago who was 22, and she'd smoked since she was 12. So very much as Sue's described, you know, childhood, starting in childhood because of what she sees in the people around her. And we're not talking generations ago, this is our generation now. She smoked for 10 years. She got a 5-year-old at home, and she'd just given birth to 2 twins and showed me the pictures, a little boy and a girl. And I said, oh, you know, would you like any help to stop smoking? Have we offered you some? And she said, I wouldn't be able to. I've smoked for 10 years. It's too late at 22. And I said, oh, well, I'll walk out with you because you can't smoke here, and walked with her and chatted with her. And she'd been offered a referral to stop smoking services at Booking In and just said no because she didn't think she could. And I started to tell her about what was available. She'd never heard of Champix. She believes what she sees on Facebook about vaping being even more harmful than smoking. So, you know, hadn't even considered that. What's even worse is that her mum had died in her 40s of a respiratory condition as a smoker. So she was taking the babies home to live with her nan, who was a smoker. When I talked to her and told her what was available, she bit my hand off. You know, she wants help. She took a prescription. I went back up and got a prescription for Champix and referred her into support. So people want help, much like Deborah said. You know, we're voicing this and acting this on behalf of smokers. They want and need help, and they realise that this. You know, this is a young woman who become addicted in childhood in a current generation because smoking is endemic in our poorest communities. Because teenagers can buy cigarettes, you know, she's 12, 13, she's buying them off, her 18-year-old boyfriend will be buying them, and that's legal. The teenagers can buy a product that has a 50% chance of killing them. She definitely does not want to smoke. She's already lost her mum. You know, there can't be a more powerful incentive, but she can't stop by herself, and she needs us to reach out. She certainly can't afford to smoke, taking 2 twins home. And I see every day people lifted out of poverty because they've been able to stop smoking, telling me they've got £300 in their wallet for the first time in their life. So it's so powerful when we can help them. She, more than anything, she really doesn't want her children to smoke, and exactly like Sue says, that's what's got to be at the forefront of our minds. They're going to be 12 soon. We need to act now for this generation on the timescale that we've suggested with a Smokefree 2030. We're just not reaching these groups with the existing provision and extent of services that we've got at the minute, and we need funding to do much, much more, particularly to target the neediest communities. Since embarking on the journey of becoming a clinical lead for the tobacco agenda in the North, I'm working with some absolutely inspirational people, many here today. And, you know, from those at ASH, Fresh, directors of public health, members of on local authorities, our local councillors are phenomenal, gone on to be local MPs. Everyone wants to do more, and we can do so much more together. You know, have a really powerful combined voice that we're all acting together on the same agenda. I would really urge everyone to use this current momentum politically, you know, as post-COVID, as the most important levelling up strategy. It's the absolute foundation, the bedrock for tackling health inequalities, is to tackle tobacco dependence and smoking, and to really push this smoke-free agenda now, all pushing together at once, chiefly by endorsing this report, all singing from the same hymn sheet, forging and maintaining cross-system relationships, as I've been able to do in the North East, thankfully, and just getting the best possible outcomes from those who need it the most for us, who I'm looking after every day. Thank you.
Thank you so much, Ruth. And as people can see, you've taken time out of your busy schedule as a respiratory consultant to talk to us today, because this matters so much to you. Unfortunately, David Fothergill is having difficulty getting back in to the webinar, so we're dealing with that, but we're going to hand over next to Dr. Emma Beard from University College London, part of Spectrum, who helped develop the recommendations and modelled their impact. She'll now give a summary presentation of the key policy interventions recommended by the APPG. And the UCL modelling for the report is available on the Open Science Framework, and there's a link from the report. I'll hand over to you now, Emma.
Thank you, Deborah. So to start with, just to introduce Spectrum, who were part of providing evidence to the APPG. So the Spectrum Consortium provided evidence to the report on smoking health, and also modelling-based recommendations for the forthcoming tobacco control plan. This modelling was conducted by the Tobacco and Alcohol Research Group at University College London, which I'm part of. The Spectrum Consortium is funded by the UK Prevention Partnership, and it's led by Professor Linda Bold at Edinburgh University. It involves co-investigators and collaborators from 10 universities in the UK and 1 in Australia. And in addition, the consortium brings together leading alliances such as Public Health England. The focus of the consortium is the commercial determinants of health and health inequalities, with a focus on the population level on tobacco and also alcohol, but it also actually extends to unhealthy food and drink products as well, where appropriate. In this presentation, I will overview the progress to date and then outline the APPG's recommendations for a smoke-free 2030. The assumption is made that the recommendations in the report would be included in the Tobacco Control Plan for England to be published this year, and that they would be implemented by the financial year 2022-2023. This slide shows data from the ONS Adult Population Survey. We can see that there has been a steady decline in smoking prevalence over the past decade. However, if we continue at this rate, it has been estimated that we will miss the target of it being smoke-free by 7 years. This is where we have a prevalence of less than 5%. And this will be double for the poorest in society, so perpetuating inequalities. Currently, there are nearly 6 million smokers in England, so that's 1/7 of the adult population. And in order to achieve the target of a smoke-free 2030, we need to motivate more smokers to quit with the help of the most effective quitting aids, while reducing the number of children and young adults who start smoking each year. This graph shows the prevalence of smoking across social grades. So it's clear that there are large inequalities which have persisted over time. In 2019, fewer than 1 in 10 professional and managerial workers smoked, well on the way to the smoke-free target of less than 5%. This is compared to nearly 1 in 4 in routine and manual occupations. Smoking is also the single most important modifiable risk factor in pregnancy. It can lead to miscarriage, premature birth, stillbirth, and cot death. The government's current ambition is to reduce smoking prevalence in pregnancy to 6% by 2022, but rates at national levels are stubbornly stuck at over 10% and have been for the past few years, since 2016. Smoking rates among those aged 11 to 15, and this is a time where smoking uptake is established, have gone down during a time when there has been substantial ratcheting up of tobacco control interventions. All of you will be familiar that there's been a substantial impact of interventions like smoke-free public places legislation, the point of sale display ban, a ban on smoking in cars carrying children, as well as plain packaging and larger health warnings. But all of this has now been banked, and we can't assume that smoking rates will continue to decline, as we have seen over the past few years, at current rates without further ratcheting up. The APPG report recommends that in order to set the course for a smoke-free 2030, that there is legislation to make tobacco manufacturers pay for Smokefree 2030 fund to bring an end to smoking. It acknowledges that we are world leaders in tobacco control, having been instrumental in the development and adoption of the WHO World Health Organization Framework Convention on Tobacco Control and the development of the evidence base for tobacco control. And we can continue to be world leaders by putting several measures into place, including protecting public policy from the tobacco industry. The report also emphasises the need to set interim targets for 2025 and to update this strategy where necessary. In order to be able to achieve this, improvements are needed in data collection and analysis, which includes more rapid access to key data sets. Several behaviour change and policy interventions are given, which involve targeted investment to level up and reduce inequalities, and low-cost policy interventions to shape the environment and denormalise smoking. So the following slides will cover these recommendations in more detail. Several policies are recommended in the report which target individuals to level up and reduce inequalities. There isn't sufficient time to cover all of these policies, so we're going to focus on the behaviour change campaigns and financial incentives for pregnant women. The report includes detailed evidence for all of these recommendations, and also, as Deborah said, the full details of the modelling which was conducted by UCL can be found on the Open Science Framework. Multimedia campaigns have been shown to motivate quitting, discourage uptake, and also encourage smokers to use the most effective means to quit. And this is generally stop smoking medication with behavioural support. In the figure, you can see a similar correlated trend in spend on tobacco campaigns and the number of calls to NHS helplines. The cut in spending in England since 2008 has been shown in several studies to be associated with a sustained fall in quit attempts. At UCL, in our tobacco and alcohol research group, we estimated that a sustained campaign with uplift, particularly in the North and Midlands where smoking rates are very high, could deliver 164,000 extra quit attempts and 7,000 extra long-term ex-smokers in the first year, among those in social grades C2, D and E. These are those who are in the most deprived situations. This is quite cost effective. It equates to roughly £170 per quit attempt. As noted on the previous slide, smoking at a time of delivery has remained stagnant in recent years at around 10%. Studies have shown that significant declines can be achieved when pregnant smokers are given financial incentives and smoking cessation advice. Provision of financial incentives has been shown to be cost effective across studies. The UCL modelling estimated that if delivered to all smokers, then prevalence could be reduced to 3.2% by 2030, which is on track for a smoke-free generation. Several low-cost policies are also recommended in the report which aim to denormalise smoking, so to stop uptake. There's not sufficient time again to cover all of these policies, so I'm going to focus on closing loopholes and increasing age of sale. The report obviously includes all of the detailed evidence, and this modelling is also found on the Open Science Framework. The APPG recommends supplementing health warnings on packs with help to quit messages inside packs and putting health warnings on cigarette sticks and rolling papers, as can be seen in the pictures displayed. Spectrum researchers in collaboration with ASH have also identified loopholes in existing legislation, particularly on the ban on flavours, which needs to be strengthened to be any flavours, not just so-called characterising flavours, and to cover all tobacco products and accessories. And obviously this may be easier now that we are out of the EU. Raising the age of sale should be subject to consultation, and it's important to consult children and young adults in particular, as they will be most affected. This is the sort of policy which will only work if it's understood and supported, like smoke-free places laws, which had over 95% compliance from day one. There is good evidence for this measure. We see this from data in England when the age of sale increased from 16 to 18, but also several US states have increased the legal age of sale from 18 to 21. With our UCL modelling, we estimated that smoking prevalence in 18 to 20-year-olds would fall by 30% if the legal age of sale was increased to 21, resulting in 95,000 fewer smokers in 2022 and an additional 77,000 fewer 18 to 20-year-olds taking up smoking long-term until 2030. This would reduce smoking prevalence to 2% in 2030. So in summary, the APPG report sets out a strategic plan of action to make England smoke-free by 2030. To set the course for a smoke-free 2030, it's important that legislation ensures that manufacturers pay to bring an end to smoking, and that we take our place on the world stage as global leaders in tobacco control. A comprehensive set of policy interventions supported by evidence are proposed in the APPG report, which are recommended to be included in the government's forthcoming tobacco control plan. They will work together synergistically to increase the rate of decline in smoking prevalence significantly, and even more importantly, to reduce the high level of smoking-related inequalities across society. However, as the government itself acknowledged when it announced the Smokefree 2030 target, it is extremely challenging. Therefore, it's essential that interim targets are set for 2025, progress is carefully monitored, and that the tobacco control plan is reviewed and further action is taken if we are not on track by then for Smokefree 2030. It is recommended that a consultation is launched also at the time of the publication of the tobacco control plan to identify the additional data which may be needed to assess the effectiveness of any policies. This slide provides further information and will be available after this session. It gives details of the APPG report, the UCL modelling link, and also a briefing paper on the Smokefree 2030 Fund. So just to finish, to also acknowledge again that a lot of this work was supported by Spectrum, which is funded by the Prevention Research Partnership, of which UCL is one of the members. Thank you very much, and I'll hand back to Deborah.
Thanks very much, Emma. That was brilliant and a very rapid run through. And can I remind everyone that if you have questions for Emma, do put them in the chat. I'm now going to hand over to David, and fingers crossed, second time lucky. Thanks, David. Let's hand over to you.
Thanks, Deborah. I hope you can hear me all right this time, and apologies that there was a technical problem before. And that's what it's a bit like when you live down in rural Somerset, I'm afraid. So I do welcome the opportunity to speak today at the event as delivery of the government's 2030 ambition is core to local authorities' public health objectives, and in particular building back better and fairer after the COVID pandemic, and therefore reducing inequalities. So since the transfer of public health to local government in 2013, we have proven ourselves, I believe, to be very effective in protecting and improving the health of our communities. Since 2013, smoking rates have been reduced by a quarter in England to their lowest level of 13.9% among the general adult population. And in my own authority's area, they're down to 14.4%. However, smoking is still responsible for around 1,300 deaths a year in Somerset. And that's why tackling smoking is still a priority for Somerset County Council, where I'm the leader. And that's why we're proud to be an early adopter of the local government declaration on tobacco control, which has since been signed by over 100 councils across England, demonstrating their commitment and our commitment to tackling smoking for the benefit of our communities. A key part of the declaration is the commitment to living up to our obligations under the WHO Framework Convention on Tobacco Control, which requires government, local government, and all public authorities to protect public health policy from the commercial and vested interests of the tobacco industry. So the tobacco industry repeatedly attempts to interfere with public health policy in the UK. This often involves the offer of partnership or help for local government, such as partnerships and non-enforceable agreements, and they must be rejected and interactions with the industry limited in accordance with Article 5 of the FCTC. Local government is a key partner in the delivery of the government's Smokefree 2030 ambition. However, although we will continue to be committed and ambitious, it is hard to deliver without long-term sustainable funding. The last government tobacco control plan in 2017 shifted the emphasis from action at the national level, legislation and mandation of services, to focused local action supporting smokers, particularly in disadvantaged groups, to quit. But the last plan did not deliver the funding needed for local government to be able to deliver the fullest extent. Since 2015, the public health grant has been significantly with the Health Foundation estimating that a minimum of 1.2 billion is needed to restore public health funding back to its 2015 levels, and a further 2.6 billion needed to level up public funding across the country. That's why I welcome the APPG on smoking and health proposal to use a polluter pays approach to deliver sustainable funding for tobacco control. And that this is a part of a comprehensive strategy set out by the APPG, which also includes a set of low-cost policy interventions to help denormalise smoking, like warnings on cigarette sticks and targeted investment to level up and reduce inequalities in disadvantaged communities. I do welcome the opportunity to speak, and I really do give you my apologies that I've had the technical problems, but I've enjoyed listening to what I've been able to hear, and I continue to look forward to the rest of the presentations. And back to you, Deborah.
Thanks very much, David, and thank you for persisting. We very much appreciate it. The LGA Community Wellbeing Board performs a really important role for local authorities, and it's great to have you speaking, both in that role and as leader of Somerset County Council. I'm now going to hand over to Dr. Henry Featherstone, Policy Advisor, who will talk about how the plan could and should be funded. His detailed briefing for the APPG is up online for anyone who wants to know more after his presentation.
Can you see my screen, Deborah? Sorry, I'm
Yes,
new to this.
yes, we can.
Perfect.
We can see your screen. I'm on the first slide.
Okay. So very quickly. So hi everyone. My name's Henry Featherstone. I just want to make clear. So I'm appearing here as a personal capacity. I do have a day job working for a pharmaceutical company, and the significance of that will become evident as I flash through some slides. So I've only got 4 slides. They're a bit text heavy. But that's just the way I'm working at the moment. So if I try and click on to the next one, let me see. Okay, so 4 kind of seemingly unrelated facts that kind of explains the problem. So I think, as we've heard before, we've got we need to put rocket boosters under the government's stop smoking ambition for 2030. Key thing from my point of view is that it won't be realised in the most deprived communities for can you still see my screen? Because I've gone to a different view, that's all. Okay, I'll crack on. It won't be achieved in the most deprived communities for the next until 2045, and we're seeing quite a lot of poverty, tobacco poverty, so household children in poverty. And from my point of view, so further tax increases are going to be particularly unhelpful. Number 2, before COVID, the government was wedded and started to think about this, committed to this polluter pays type principle. Okay. Number 3, there's no more money left, and there really is no more money left. So government borrowing £303 billion just in last year. And then seemingly unrelated fact number 4, there's a tobacco company oligopoly. Okay, so 4 are also tobacco companies operating in the UK market with a massive market share and market power, so over 90% of the market. It looks, and it's very difficult to work this out, okay, it looks like they're sort of making profits of about 900 million and margins between 50 and 70%, okay. This work has been done by the University of Bath, Anna Gilmore and Rob Branson, rather than myself. And what seems to be happening is that when the tobacco tax increases come in, companies also increase the ex-factory sales of their products. So they're making the price increases don't impact consumption that much, but it does impact their bottom line and their profitability. Okay, so what could be done? Okay, so it's not a perfect analogy, but where my background is understanding the pharmaceutical markets. And for pharmaceuticals, there is a pharmaceutical company profit cap and price control scheme in operation. It's been in operation since the 1950s for a very long period of time, and it does raise significant amounts of money, about 500, 600 million pounds per year. The reason that that is necessary is because when you grant a patent on a particular line of medicine, that grants a temporary monopoly over the price. And this was put in operation before NICE started looking at cost effective of medicines. And now the government's actually got the best of both worlds. It's got the price cap and control scheme and NICE. Second point here is the Department of Health has huge amount of expertise in monitoring these company profits and closing loopholes through the evolution of this pharmaceutical scheme. So every 3 to 5 years, tend to be every 5 years, the pharmaceutical scheme is renegotiated. What also happens as well is that the pharmaceutical scheme is quite sophisticated in that you can encourage pharmaceutical companies to do the sorts of things you want. Okay, so less spending on marketing and salespeople, more spending on innovation and research and development. And the third point here, what have we done? So Brexit. You didn't think you'd be hearing about the positive opportunities of Brexit in relation to tobacco, but in the point that's important here is Brexit now allows the UK government to set tobacco prices. No longer part of the excise duty regime that operates in the internal market. And in terms of how much control do they already have already, it's about 88 to 90% of the tobacco price is VAT and excise duty. Okay, so what's the grand plan? Okay, so the central proposal here is to have a profit cap and price control scheme for tobacco companies based on the best bits that has been in operation for the pharmaceutical companies over the last 50 or so years. Three very distinct and very clear objectives. Number one, control the market power and limit the profits of tobacco companies. How do you do that? You do it by what's requiring an annual financial return. So very, very detailed audited accounts that are submitted to the Department of Health. Department of Health is already looking about 20 or 30 or 40 of these every year for pharmaceutical companies. We're only asking them to look at another 4. Profit cap, and again, this is a suggestion. The suggested profit cap for tobacco companies should be about 10%. Pharmaceutical companies, it's between 17 and 21%. And as we might have been hearing in the news around the G7, digital companies, anywhere around to about 15%. And the way it's implemented, we suggest it's implemented, again, is the way it's done for the pharmaceutical scheme. It's a simple sales-based levy on the pack price or a cigarette, the per cigarette, per stick price of tobacco. And in order for that to happen, the first thing that does need to happen is you need to level up the disparity between normal cigarettes and hand-rolled tobacco. Second thing, what we're trying to do with this very explicitly, we're trying to change tobacco company behavior. So they start focusing on e-cigarettes and vaping products, so less harmful products. Okay, and you can do that in the same way that you do incentivize or not disincentivize invention and research and development for pharmaceutical companies. And the third thing, very explicitly here, we want to raise funds to fund the Smokefree 2030 ambition. Okay, current calculations, we're thinking you could raise about £700 million a year through this scheme, of which we're suggesting 315 or so should be retained by the Department of Health to go for funding the Smokefree 2030 initiative. Again, we're very clear that the money goes straight to the Department of Health and then it retains, and there's possibly an opportunity to do some other good work with the surplus for other public health initiatives. Okay, so what should happen next? So as many of you might know, there's an NHS bill announcing the Queen's speech, currently being drafted. You just require 10 paragraphs of primary legislation that would give the Secretary of State both profit and price capping powers over the tobacco industry. And as you've heard before, great level of public support for this polluter pays approach, where you specifically take tobacco companies to pay for tobacco cessation initiatives. You can then at your leisure design the secondary legislation with the Department of Health, with the expertise and the learnings they've gained from the pharmaceutical scheme, certainly over the last 50 or so years. One of the key things from our point of view is the information gathering powers that will good. So you can find out the cost of goods, the distribution margins, you know, the very small sales and marketing spend. And this data can then be published in aggregate form for committee review and just increase the general transparency. And then the third point here is the creation of this new Office for Health Promotion in the Department of Health seems to be a key organisation to be very, very instrumental in administering the Smokefree 2030 fund. One of the things we have flagged out is you've got a very strange anomaly here where you're trying to fund something from the thing that you're trying to ban. So we need to think carefully how the end of the scheme comes into operation. but certainly for the next decade, this does seem to be a very good way to fund the programme. And on that, I will hand you back to Deborah.
Thanks very much, Henry. If we can get the slides down and ask the participants to put their cameras on again. So we're going to go to questions now. And just to remind you, you can put questions in the chat. Can we, yeah, in the right-hand side. And do you want to take that slide down so we can actually see people now? First questions for Henry. First of all, what about the devolved administrations? We know the Smokefree 2030 ambition is for England, but would the fund provide money for the devolved administrations too? And secondly, can we be sure that the fund would be in line with our obligations under the WHO Framework Convention to protect public health measures from the commercial and vested interests of the tobacco industry? Oh, you're on mute.
There we go. So on the first point, anything done by the UK Parliament would be a UK-wide price control scheme, so that all the money would go to the Department of Health, and it would then be the department to make the separate allocations to both Wales, Scotland, and/or Northern Ireland, as currently happens with the pharmaceutical scheme. It's then up to the devolved administrations to determine what they want to spend the money on, however. In terms of obligations under the tobacco control scheme, this would be a fully statutory scheme. So it would be the law. There would be no discussion, negotiation, or ability to lobby by the tobacco industry. So as I understand it, it would be compliant with the WHO Article 5, is it 5?
Article 5.3. Thank you very much, Henry. And actually, I'd like to go now to David Fothergill. Having heard about the fund in particular, does this sound like something that the LGA would be able to support? Oh, you're on mute.
Deborah, I think you're muted.
Sorry, I'm muted. I was talking away without. We seem to have problems with David's sound again, so I think we'll ask if he can put a response in the chat. But I'd like to come to Emma now, because I've had a couple of questions for Emma. First of all, on the age of sale, would this need to include vaping products? What would the impact be in addition to the impact on 18 to 20-year-olds? Because we know the Institute of Medicine modelling in the US did look at the broader impact on younger smokers as well.
Okay, starting with the first question, this is in relation to should vaping also be increased to age 21. From my point of view, and ideally based on the evidence, no. The idea would be that if smoking was increased to the age of 21, then those smoking who are younger could actually get off tobacco by using e-cigarettes. We don't want to make them harder to get hold of. E-cigarettes are very effective to help people stop smoking, extremely less harmful than cigarettes. In response to the second question, the reason we modelled 18 to 20-year-olds is because this is the age group for which it would become illegal to smoke while it is currently legal. It's easy to model because we have data available for that group from the US, and also based on the previous studies when it rose from 16 to 18 within England. But obviously uptake would also be reduced in younger age groups because they would find it harder to get hold of cigarettes, often getting hold of cigarettes from older people at their schools, peers, and so on. And I'd also envisage an impact in older age groups through kind of the denormalization of smoking. So for this modelling, we only focused on the 18 to 20-year-old age group because it was easier to model because of the data, but there would definitely be an impact across age groups.
Thanks very much, Emma. That's really helpful. There was another question about whether shisha is included in the menthol ban. It's not. The menthol ban only relates to cigarettes and hand-rolled, and it's also only for characterising flavours, not all menthol flavours. But that's something we're pursuing separately. I'd like to come back to Sue, basically, on the age of sale and how you feel about that as someone who started smoking so young.
To be quite honest, if the age of sale went up to 21, there's no way me as an 11-year-old, or even I see young kids, I live just across the road from the school, young kids can put makeup on, but they won't look 21, they'll look 18, 17, 18, where a shop owner might go, oh, but 21, from a 13 or 11-year-old to look 21 would be incredible. So I would definitely back up in the age, 100%. It stops the young ones getting addicted.
And Ruth, I can see you nodding. I'd like to come to you on that, particularly on, pregnant smokers, which you were talking about so movingly earlier, because we know that the highest rates of smoking in pregnancy are amongst teenage pregnant women.
Absolutely, and it's sad, isn't it, that this is still this generation. The patients I'm seeing in clinic started smoking in childhood, but they're in their 40s, 50s, 60s. When we've got 20-year-olds who started smoking age 12, it's, that's definitely where the intervention needs to be. And as Sue said, young teenagers hanging out around with older teenagers, it's very accessible for them at the minute, and the further we can lift that away from them, it will definitely be of benefit.
I'm just trying to keep a track of the questions now, and I've got a request for you, Sue, if you can turn up to a meeting for someone. I think your speech was so impactful, so we'll put you in touch with the person who was asking about that. I think the next question I have is around, are there any examples of particular regulatory good practice for local authorities which attendees could take away from today? Sadly, I think that we've lost David, so I can't ask him to come on that. But certainly Ash does evidence into practice briefings and various other things. So if you're interested in that, email us and we will get back to you. Question for Henry. Are you worried about the ethical issues with tobacco companies using profits from vaping products to promote tobacco products?
I don't think that's the intention or how that would be possible. The intention is that you tightly control everything within the UK perimeter and that you're effectively not promoting using any cross-fertilization from non-tobacco to tobacco. So as the way the scheme is in my mind, it's going to be very, very tightly regulated, and there's going to be no cross transfers there.
Someone's asking where the funding would come from for incentives, but I think that question has been answered by you, I think, David. Henry, sorry.
Yeah, so it's disincentives. The absence of a disincentive is an incentive, if you follow my ministerial logic.
Another question for Henry. Someone's asking whether you were implying that further tax increases may not be helpful, but is it just that this is actually a separate mechanism because tax is not hypothecated in the UK?
Yeah, absolutely. So you would still increase taxes over time to make the affordability of cigarettes slowly increase in time, but unless you regulate the price and the profits, what happens is tax increases will be jumped upon, used in aggregate, and you'll get ever more profitability of tobacco companies. So we're seeking to do both. We want to control the price, which should probably go up over time. So tax take, there'd still be a significant tax take, but this is a tax or a levy directly on corporate profits, which are So 900 million profit on about £2 billion worth of sales. That's I think the contention is that's excessive.
Thanks, Henry. I'd like to come to Emma now. Someone's asked in the chat, said this is brilliant modelling for England, but is it possible to do the same for other parts of the UK, Wales and Scotland and Northern Ireland?
Yes, certainly. So if you go onto the Open Science Framework using the link in the presentation, all the Excel files are in there with how we did the modelling, and you can just adjust some of the parameters to Wales or Scotland, for example. It will just require you to put in things such as the current prevalence rate there, as opposed to what we have in England. If you were interested or had any further questions, I'm also happy for you to email me if you need any guidance.
Thanks very much, Emma. I'm going to come back to David now and hope we can hear you this time, David. I don't know if you had a chance to hear my question and the other question put to you about the sort of things that local government are doing on tobacco control, which are really useful for other authorities to hear about. Oh. No, we're still not hearing you, David. I am sorry about this. It's very frustrating, but we'll have to catch up with you after the meeting. I think that's the best thing to do. But thank you particularly so much for joining us and for staying on despite the technical problems you've had. It's very much appreciated by everyone. So I think we're sort of moving towards the end of the event and my turn to wind up. So I will just do a quick check that there's nothing else that I've missed on the questions. And yes, there's a question from Dr. Ruth Sharrock about using Champix in Gateshead. Would that be a possibility in other places like Cumberland Infirmary, Carlisle? It sounds like use of Champix is not necessarily always widespread, and I know there are problems with access at the moment. I don't know whether you've seen the email from the NCSCT, so I wonder if you pick up on that and actually cover the fact of what's to be done if Champix isn't available. It doesn't appear to be at the moment.
Yeah, no, it's an absolutely vital tool in our armoury, and it's so successful. Patients just get on really, really well with it. About 2/3 success rate for quit attempts. So I was very upset when I heard we had supply issues. I only heard yesterday. I did wonder if I might be the reason for the supply issues. But yes, it needs to be accessible across the NHS. It's such a valuable tool for people making a quit attempt that we need to have it as part of the pharmacotherapy resource available across all trusts, especially if we're investing in an acute tobacco dependency service. We need to give them the tools to use. In the interim, it's difficult. The success rates are equivalent with vaping. There tend to be people who, you can clearly split into the two camps, aren't there? The ones that will do well just with nicotine replacement therapy products, and the ones that have struggled with them and will do well with Champix. And I suppose as an interim, vaping has got the equivalent success rates and probably is the best tool for people who won't do well with NRT alone.
Thanks, Ruth. I mean, in your area, do you presumably use combination therapy, so more than one NRT product at a time, but you still find that Champix, or varenicline as it's also known, is a more successful product, do you?
Yeah, I mean, I'm obviously seeing the tough cookies, aren't I? The people who are having health complications from smoking or being diagnosed with cancer, it's exactly like Sue said. There's, they've got every reason to want to stop smoking and they still can't do it. So plenty of people are well served with, as you say, combination NRT patches and some quick go-to. But there's just a big cohort, certainly of what I'm seeing in hospital, that can't manage with that, and Champix or helping them get onto e-cigarettes instead is critical, vital. You can probably see in the background, but our domestics on the ward help advise people about vaping. They're all ex-smokers, and give them advice and help them source products. And you know, this needs to be part of a mainstay of our services, and it's what we're working very hard to provide.
That's a really helpful last message. So if you can't get hold of Champix for your patients, do try and encourage them to vape instead if they're not finding NRT helping them. I'm now going to wind up. So thanks to all the presenters, you've been brilliant. And can we come to the last slide, which tells you what to do next? So basically, just to sum up, can I reiterate the importance of getting a bold new strategy to achieve a smoke-free 2030. Modelling by Cancer Research UK shows that we are not on track, and we're certainly not on track for the most disadvantaged smokers in society. So what we'd like you to do is to read the whole report and preferably endorse it as well. So can you email admin@smokefreeaction.org.uk and let us know your name, your organisation, if you're doing it on behalf of an organisation. Send us your logo if it's an organisational endorsement, whether you'd like to be informed about progress. And what I'd say is that we've already had some very significant endorsements for the APPG report from the Academy of Medical Royal Colleges, the RCP, Faculty of Public Health, etc., etc., etc. So do endorse and put your name alongside the leading health organisations in the country. And we'd also like to encourage individuals to email their MPs and urge them to support the report and recommendations. And you can do that by looking on They Work For You to check who your MP is, and just send a personal email. It's better to send a personal email saying why it matters to you than to do some kind of template, but we would encourage you to do that. Thank you all very much for attending today's webinar, and this is just the first step on pushing to have the best possible tobacco control plan going into the next 8 years, slightly less than 9 years, before we have to achieve and must achieve, for the good of society, a smoke-free 2030. Thank you.